So welcome everyone. I'm Tori Barr. I'm a MedPeds complex care doctor here at Gillette, and one of the members of the core faculty of this ECHO project. We're so excited to have you and have just a really exciting conversation in store for you today. Katie's pulling up our slides and looks like they'll be here shortly. So again, we are very fortunate to be able to put on this ECHO series because of the support of all of these incredible organizations down here on the slide: Gillette, the Got Transition National Program, Project ECHO, the Minnesota Department of Health, and the Copic Medical Foundation based in Colorado. We'd love for you to introduce yourself in the chat so we know who is all here. And together, we're all going to talk today and learn how we can transform Minnesota, and for those of you outside of Minnesota, anywhere, healthcare systems to provide equitable, accessible, and trauma-informed pediatric to adult healthcare transition for all Minnesotans and really for all people. We've been fortunate on this ECHO to have attendees from India, from Canada, from many, many states and many, many counties across Minnesota. Slide. Again, we can't do this without incredible funding, so thank you especially to the Minnesota Department of Health and the rest of our core faculty and steering work group, which you'll see on the next couple of slides, as well as these are all listed, including more bios on our website. So you can get to know these very passionate leaders and build connections with them. All of us are very excited to talk about transition and how we can do this work better. This does qualify for CME. You'll get information on how to get those credits in the follow-up email. This counts for 1 contact hour. So in order to really learn together and to really feel the ECHO as power, we welcome you to turn on your video so that we can get to know each other a little bit better. Mute your line if you're not speaking. You can either raise your hand, and we'll have people watching for raising hands, or throw your question in the chat. And if you are going to come off mute, just introduce yourself so we know who you are. This ECHO will be here. Welcome and introduction. That's my part. Our didactic presentation upcoming, and then a case discussion and a quick wrap up at the end. You will see a very exciting addition to our case discussion later on in the chat. But we know everyone that sees patients who are transitioning from pediatric to adults could use some added help with how to care for these patients. And what better way to get some help than to pull this incredible audience of people from across the US, from different disciplines, to really see how can we do this work better? How can we do it more equitably? How can we do it with more trauma-informed care lens? So this is your opportunity when you're seeing that patient in clinic, or when you're thinking about how do we do this system, build this system better in our clinic, to get some instant feedback on how you can do that. So it's very low stress, low key. Today you'll see that someone is going to present by a recorded video. So really low stakes, but really high reward with the ability to get some really tangible support for caring for patients. When we do a case, we're not developing any provider-patient relationships. That's per the ECHO model. And we will, of course, observe HIPAA. So, Katie, I'm not sure where the slides went, but I am just thrilled.
Anita wanted to share hers. Sorry.
Oh, perfect. Well, while Anita's pulling those up, I am just thrilled to get to introduce our speaker today. This is Anita Raymond. She is a social worker who is also the director of the Center for Excellence in Supported Decision-Making and Care Management and Consultation Services through Volunteers of America. She works here in Minnesota and is an incredible speaker. I heard her speak several years ago and came away just blown away with how we can think about guardianship in a more powerful way. She's won tons of awards. and is just such an amazing woman that we are very fortunate to have here in Minnesota. And she's going to teach us all about how we can be the best advocates for our patients today. Welcome, Anita.
Thank you. Thank you so much for having me. And as luck would have it, when I practiced ahead of time, I could find everything I wanted. And now I'm not finding the exact things I want on my screen, but that is okay. I'm just going to try one more quick thing because I don't want to take up time because I have a lot I want to talk with you all about and a short amount of time to do that. So let us get started and I will manage to not. I spent some time this morning because the topics I want to talk about today, I'm so excited about it. I'm so excited for everyone that's here that I could spend an hour, 3 hours, 8 hours on this. And so I tried very hard today to pull together my focus. And then of course, now I'm not finding my focus notes, but that's okay. We will continue and we will proceed. And like I said, I'm just very excited to be here and thank you all for having me. So of course, today you all have received in advance the objectives, what we want to get through, a very high level overview of exploring the opportunities for supported decision making. So we can think about how we're approaching supporting young adults, young people as they're becoming adults and their families. And so we can think about all of the decision-making support options and processes and thinking through as providers in our various roles so that we're helping families and patients help understand that we want to do things a little differently than historically we have. And so we want to think differently about, for too long, we have had a presumption in Minnesota, probably nationally. We're probably not the only state, but we've had a lot of emphasis on protection and safety and presumption that guardianship is the most appropriate, the default approach to recommend to families and individuals with disabilities as they're turning 18. But we want to, I'm part of a movement in my program. I'm really excited to be here. I'm really excited to lead the Center for Excellence and to lead Minnesota collaboratively across all spectrums, healthcare, social services, special education, family dynamics, to really help us all have conversations a little differently than maybe we did in the past as we think about transitioning to adulthood, as we think about those transition stages in decision making. We think about those, what we're here to talk about today is those minor children who are becoming adults, who have had parents their whole lives, or legal guardians, family members, whoever their supporters have been as their legal guardians as children, and then thinking through, but now they are turning 18 and they may still have difficulties, challenges. They may not be, people may perceive that they are not cognitively, emotionally. People believe they're not legally ready to be independent in decision making. And what we want to talk about today is acknowledging, I want to really start with a presumption that no one is completely ready for adulthood when we turn 18. If we think back to our own days of becoming adults, or many of us may have children now or other important people in our lives. I have several nieces who are recent adults. And we think about people at 18 without disabilities continue to turn to teams of supporters. We're not quite ready just at this magical legal age of majority. That doesn't mean we're emotionally or cognitively ready to navigate the complexities of adult decision making all on our own. And then, but with kids with disabilities, those conversations tend to, too often, we put all that emphasis and focus and planning on lack of independence, this leading to this presumption of they're not independent, so they have to have a guardian. It's really something we want to get away from. We want to acknowledge almost no one is ready at age 18 to be fully independent. But that's a really hard transition to make. And the way families get communicated and the way families think about that transition. And I acknowledge there may be people in this group of us today who are parents of young people who have disabilities or have other challenges. It's really hard to think about our children being adults at age 18. And it's even more so for people who have kids with disabilities. They are adults, but what about those safety concerns and those fears and those worries? So we really want to be thinking as systems, and I'm so thrilled with the multidisciplinary groups that are represented here today, because we want to think differently across the board, across our levels of intervention and our places of intervention, about how we think about supporting people, how we evaluate abilities and disabilities and deficits and challenges, but bringing on, and for some of us, it's not a new way of thinking. For some of us, it is bringing an eye towards maintaining an emphasis on what support skills and abilities are needed to help the person ensure they have what they need to get their basic needs met, but also acknowledging their preferences and their humanity. So there's a really wide spectrum of decision making, with guardianship or supported decision making on one end of a spectrum, and then complete independence on the other. And again, it's the rare person who's solely on one end or another of needing total substitute decision making or ability to have full independence, all of us included, right? And I see that I am not, okay, so I definitely have two versions happening. I have been going forward on my own screen and the slide has not been advancing for you. So you are now seeing transitions in decision-making slide, is that correct? Okay, thank you. I think now we're lined up. I'm sorry about that. Okay. So I do want to spend a few more minutes on this notion of guardianship, just because that has been such a pervasive part of the conversation. Hopefully for many of you, you're rolling your eyes, politely not showing me that, but you're thinking, that's not where I am. That's not where I ever have been. That's where I used to be. I'm no longer there. And that's fantastic. But I do want to lay some groundwork for those of us for whom this is a different way of thinking about guardianship. It has for too long been the presumption, the default recommendation to families of kids with disabilities who are turning 18. But we have to acknowledge it's not merely a benign protective tool, as so many people think it is. In fact, it's literally a transfer, a removal of rights, transferring those rights from the individual to the guardian, or in the case of young people who are turning 18, you know, they never had a chance to own the rights. Like, they become 18 and a guardianship is put in place and they've never had an opportunity. No matter how skilled, well-intentioned, person-centered the guardian is, there's just no denying that there's a power imbalance. The guardian has ultimate authority over so many of the decisions impacting that person's day-to-day life. Guardianship also comes with unintended consequences, which at best impact the person's quality of life when health and safety is emphasized over quality of life and life satisfaction. But at worst, it comes with significant risk to, not across the board, not all the time, but it can come with significant risk to the person. With overprotection can come a lack of emphasis, a lack of attention paid to helping a person to learn how to make decisions. How do we all learn to make good decisions? How did we learn to make good decisions? We got to try. We made some mistakes. We learned from our mistakes. But for people with disabilities who never get that chance, who transition from childhood as a legal status of childhood to, in some ways, and I think I mentioned it on another slide, sort of perpetual childhood of having a guardian in place, never get to try and learn. With overprotection, benign and well-intended as it is, I shouldn't say benign, as well-intended as it is, with overprotection also can come learned helplessness, and paradoxically, an increase in the likelihood of sexual abuse. likely because of that learned helplessness, as well as a lack of, again, we don't emphasize skill building too often. That's not true across the board, but too often once there's a guardian, we think, well, now they're going to be safe because I'll make all the decisions, or the family will make the decisions. And we don't think about the fact that when we're not teaching people to recognize danger, to respond to danger, and I'm talking about the example of increased risk of abuse, or a false sense of security. We think I'm saying no to many things, so my kid is going to continue to be safe. They're not going to get involved in dating relationships because I'm not allowing that to happen. But people are going to sneak and do things that they want to do anyway, and we may have that false sense of security. So a lot of pretty negative implications can happen that we never even intended as we sought to protect people. We also have some pretty significant harsh realities that can happen. Again, I mentioned perpetual childhood for people who don't have that sense of, I don't view them as an adult. I'm not viewed as an adult. Everybody has to tell me what to do. I have to ask people to do things. Have you worked with people, unfortunately, have you ever used the terminology of someone has the functioning of a second grader, or a 7-year-old, a 13-year-old? It just paints a picture of perpetual childhood. And in addition to not recognizing that people are adults with adult bodies and adult hormones and adult needs, viewing them as perpetual children, again, placing some of the dangers we talked about a moment ago, but also what can happen to the individual is that sense of feeling so boxed in. I'm so boxed in by the safety, the decisions that were made to keep me safe, that now I'm going to react with my words, my anger, my frustration, or a sense of defeat. I might act out. And I have act out and behaviors in parentheses on this slide. I think hopefully we're all becoming more and more aware. Everything we do is a behavior. Sitting here today, taking a drink of water, having a conversation, watching the screen, these are all behaviors. But when we're talking about intrusive behaviors, behaviors that come as a result of someone feeling very angry and frustrated and feeling like they're not being listened to in other ways, or they don't have the words to communicate, can lead to significant expressions of anger, and that can lead to increased requests for medication. It can lead to increased exploration of more structured living environment. For other people, it can lead to turning more of an inward, a depression. Again, that learned helplessness, that sense of isolation. So a lot of really negative things can come with guardianship, even when we think it's going to be the be all and end all, right? To try to support someone and keep them safe. We also want to acknowledge and remember that guardianship also comes, there's some limitations. It is not a power of getting a person to do something we want them to do. It's a power of consent. It doesn't magically afford a guardian the ability to get a person to do something or stop doing something that we believe is in their best interest or their safety. Sometimes we think about using guardianship to help prevent a person from getting sexually abused, from getting hurt in relationships, trying to avoid unsafe friendships, for example, or dating relationships. But the Bill of Rights prescribed in Minnesota's guardianship law says that people have the right to interact with people of their choosing. Guardians can place some restrictions on that, but only when they can really show that there's a significant likelihood, or that there's a likelihood of significant physical, psychological, or financial harm to the person. And even then, they can only restrict those interactions in ways that are, in the least restrictive ways. Okay, so we want to be thinking ahead about, even if we go for guardianship for the person's well-being and best interests, we want to make sure that we are able to do what we want to do in order to protect the person. We also need to plan for the future. We want to think about, in Minnesota law, the practical realities are for guardianships that are initiated after August of 2020 for people under 30 years old. The guardianship is going to automatically end in 72 months. Unless somebody brings a petition to extend it, and several petitions until the person reaches age 30. So we want to be thinking about for young folks at transitioning age, if we are seeking guardianship, what skills do we need? What's going to happen when that guardianship ends? Or are we going to get another guardianship? What's going to happen when that ends? So we better be working towards skills and abilities and building in supports and scaffolds now, right? If a guardianship does continue into a person's lifelong time, right, after their age 30, we want to think years and years ahead. And I would wager most families don't think about this, but we hear from families on the guardianship information line now, the family guardian, the mom, the dad, the sibling, they themselves are 60, 70, 80 years old. And they're feeling their future. They're feeling their current health. Can I continue to be a guardian? I need to find someone else. This is causing me a lot of anxiety and a lot of worry. And I know this feels like really far into the future for the people you're working with that are just turning 18 and their parents are probably in their 30s or 40s. But down the road, that is a great deal of stress, and it can be a lot harder to find a successor guardian, a court process, having to report people's financial history, background checks that are required with guardianship versus talking to siblings or other family members. Would you be willing to step in and be our person's go-to person versus having to go to court? So these practical realities of guardianship as well are something we want to think about. And again, Minnesota law is, for all these reasons I've been talking about, and I know we have people from other states too, your states are maybe very similar. Most states have requirements, and Minnesota law definitely requires a proof of incapacity and that there are no less restrictive options to meet a person's needs. Most states in the US have some similar criteria, one or both of those: inability, incapacity, and no less restrictive means to meet their needs. Minnesota law is even a little more finessed than that. It does require that we state in the petition and in the court hearing what options were tried, how long, and why didn't they work. The idea being that then and only then, less restrictive options only when they've been tried and ruled out should we be filing petitions for guardianship. Minnesota law is less interested, and I don't mean to say that a diagnosis or a testing score, a screening score is not important, because it is, and it gives us a lot of information. But we ought never be thinking about somebody has a diagnosis, so they need a guardian. It's really more about, okay, they have a diagnosis that would otherwise lead them to be unable to get their needs met, but what options can we pull together? Can we use technology? Can we use supported decision-making? Can we use the community and residential services available to us? Can the person appoint a healthcare agent? We must try less restrictive approaches before we seek guardianship. And so it's really a different way of thinking or honoring and recognizing that full spectrum. That again, on the one end, that elusive total independence, almost none of us are all the time with every decision, to total support, that's total substitute decision-making, transferring decision-making to another person. In the middle is where we want to be. In the middle is where we want to think about supporting, getting the help we need from trusted others to make the decisions. And sometimes supported decision-making does also include surrogate decision-making. Sometimes it means the person needing extra help recognizes this is even beyond, I don't feel well enough. I have other things I want to pay attention to. My illness has me too disjointed and discombobulated. I don't feel well enough to even think about it. You turn to other people, turn to my best person, turn to my person, whether I've formally appointed them in a healthcare directive or whether I'm just informally saying, please go talk to them, don't talk to me. I don't feel well enough to even hear any of this. That's surrogate decision-making. So let's spend the rest of our time on that notion of supported decision-making. And I want to make sure everyone understands that, again, and I acknowledge this is not exactly applicable to everyone if you're not from Minnesota, but Minnesota law gives us a defined definition of supported decision-making. And it's really quite simply how we all participate in decision making at one time or another, whether it's formal or informal, written down or happenstance. It's assistance from one or more persons of an individual's choosing in understanding the nature and consequences of potential personal and financial decisions, which enables the person to make the decision. And when consistent with their wishes, communicating a decision once made. And that's an important piece too, is communicating that piece. Whoops, again, I failed to advance the slide. I'm so sorry. That's an important piece too, is that communicating the decision. Even if I can participate in the decision making, but it's too scary to talk to a doctor or a lawyer or a social worker or someone in authority. I can enable someone else to make a decision for me. So Minnesota law defines supported decision making and prescribes that we must try it prior to seeking guardianship, as well as trying other less restrictive means. So this idea that supported decision making, again, nothing really earth-shaking, right? The concept of it, thinking differently about supporting people, is maybe a little earth-shaking or majorly earth-shaking, but really the principles of supported decision-making really come down to that idea of it's how we all make decisions, right? No one is completely independent. When we're struggling with a decision that's beyond our capacity, beyond how well we feel that day or in that moment or that course of illness, the complexity, we haven't had experience or knowledge, all of that is when we turn to trusted others. What would you do in this situation? Or I'm just so flummoxed. I know what I really want to do is get together with my friends tonight, but I didn't get my car. This isn't a real example because I do have snow tires, but I didn't get my car ready for winter, and it's going to be dangerous to me in this snow. Those of you from North Carolina don't know what we're facing necessarily. It's going to be dangerous tonight in the snow to drive my car to get together. What should I do? And turning to my trusted others to talk about, well, how maybe you all should reschedule. Maybe you can meet in, FaceTime to get together. Using a simple example, but to demonstrate that supported decision making is applicable to all of us. And by the way, we know this anecdotally, and we know that the research definitely backs us up, that people who enjoy a sense of agency, have that sense of awareness, that sense of self-determination, have better outcomes. A lot of research out there that backs it up. People are more able to be independent, live in community settings, have gainful employment, more well-adjusted, better able to recognize and resist abuse. So much psychologically and strength-wise comes from having that sense of agency, rather than having someone else be appointed to make the decision for us, and perhaps we'd be left behind. We all play an important role in helping people navigate this, whether we are, again, Department of Health, special ed, physicians, social workers, school social workers, whatever way we intersect with individuals and families. How we talk to families about this transition to adulthood makes a significant difference to the family's willingness to try options other than guardianship. It's a really complex decision. It's different for every patient and every family, every student, every young adult. The key thing is for us as practitioners to understand, to think differently about supporting people, think differently about getting away from those ableist ideas of disability equals vulnerability equals can't, to disability equals humanity, human rights, dignity of risk. We all, regardless of our functioning status and our diagnoses, we want the same things. We want to be able to be involved in decisions that impact our lives. So our role as professionals is indeed to help identify and help families identify, yes, those decision-making challenges. Start with a presumption. We're not even going down the guardianship role, thinking to all the different ways that we can help support an individual without having to even think about interventions. Like, start with, where are those areas of concern? Are we worried about, well, they don't know how to manage their money? They don't understand the complexities that credit cards are not just a free thing. A debit card is not just free money. There's implications, but if we've never given them the chance, how do we know? So identifying the areas of support, money management, healthcare conditions, applying for services in the community, continuing to participate in special education planning, life skills, dating, community safety, all of the things that we have to face as we turn adults, and thinking about what tools are out there, what under that umbrella of supported decision making can we use to build in to accommodate the deficits, the challenges. Somebody can't manage their money. They don't know about SSI, supplemental security income, or other benefits through Social Security Administration. Okay, let's talk about representative payee, where someone else is appointed by Social Security, or maybe we're a co-signer on a bank account, or maybe we're helping them get a bank account and helping them learn how to budget and so forth and not overdraft, use a debit card. But maybe we're going to be, with their permission, view online. We're going to log on once a week or however often is appropriate to take a look at the money going in and going out. We can establish for families who have more substantial amounts of money that the person's going to inherit, and we can't just hand them, a huge pot of money. Well, maybe we work with a lawyer to set up a power of attorney or a trust. Maybe the individual maybe they can't understand the first thing about their complex healthcare decision, but they sure know that they love it when their parents, their two moms, their mom or dad, their brother, whomever, they sure love it when that person helps them go to the doctor, get their medications, do the pharmacy refills. Maybe they can appoint a healthcare agent. Maybe they have sufficient capacity to still do that. Families can obtain medical assistance waiver, community-based services for individuals working together. They don't have to have guardianship for that. The most best kept secret is a release of information. But my kid can't, even as an adult, they won't be able to. Well, sign a release of information. And then you would be able to communicate with the doctor, the pharmacist, the school, the social worker, the whomever. Another great opportunity that some people, those of you in social services, are aware of, but some families might not be, and physicians might not be aware of, but person-centered planning processes. That's an excellent approach where we sit down with the individual and their community of supporters and work through what are their dreams, what are their goals, what's needed to get there, and can build in and reveal going forward what is needed to get to their goals in the realm of helping manage money, helping connect to services, and so forth.
2 minutes, Anita.
Okay, thank you. Yes, and luckily I'm getting close to done. So again, continuing to work with the individual, what their needs are. Can we do harm reduction? Can we use technology? Just countless ways to support a person with their with whatever it is they need without having to seek guardianship. It's all about building in supports. It's not this idea of they can't make their own decisions, or they're their own decision maker, so whatever they decide we have to live with. Nope, it's building that community, those relationships, what I like to call scaffoldings of support, working towards as safe as necessary, getting away from the idea of as safe as possible. I have that on the last slide. That's a phrase we think about a lot in our office: as safe as necessary, not as safe as possible. Because if we all were as safe as possible, we would never do anything. I've given you, these are live links in your handouts, lots of resources to share with families, lots of resources for you to explore further on your own. I want to remind everyone that for in-depth case consultation, our office, we host the Guardianship Information Line, free families, professionals, individuals subject to or at risk of. More resources on our website, and I know I need to be done. I want to also really talk about, I'm really impressed with Catherine McLaughlin at Elevatus Training. I mentioned earlier, I quickly mentioned dating, relationships, healthy relationships, fears of somebody because of their disability might not be able to understand. This Elevatus Training resource is a wonderfully adaptive resource for professionals, families, or individuals at whatever level of understanding a person with a disability might have. We also have some great resources in Minnesota through the Disability Hub. Did I give you this handout I cannot remember, Katie, if I gave you this handout as
I
well.
Nope, I don't believe so.
Okay, I will
Nope.
forward it to you and you all can share this. This is just a great conglomeration of what I've talked about today. And I am finished with my piece. Very high level, very fast, a lot of really important content. And again, I thank you for your attention and for this conversation and this topic today in your Echo series. Tori, I will stop my share.
Thank you so much, Anita. Hi, everyone. My name is Alyssa Green. I'll be facilitating the second part of this session, but I just wanted to make sure we have a minute or two for some quick questions for Anita. You feel free to put them into the chat or come off mute and introduce yourself if you have any questions for Anita.
I love Becky's comment in the chat. I use that phrase, their own guardian, and I didn't go on to say exactly what you're saying, Becky. You and I both. I hate that none of us ever introduce ourselves. I'm Anita, and I'm my own guardian. I'm Anita, and I make my own decisions. You assume I make my own decisions until you learn otherwise. So you see my supporters. Absolutely, how we should be that. Are you your own legal or decision maker, or who helps you? Who might help you if you need help? Absolutely. Yeah, Pacer is another great resource. Absolutely. Yeah. Arun or Arjun, I apologize if I get the name wrong, you acknowledging that you used to in your community use those phrases, and it sounds like past tense of the 8th grader functioning like a 2nd grader. And I appreciate that we turn away from those ideas, those ableist language tools that keep all of us with that filter of they're a child instead of they're a grown-up with significant or minor support needs. Thank you.
And we have one question that just came into the chat. In Minnesota, how do families tend to learn about supported decision-making? Are there workshops?
Yeah, excellent question. We don't have scheduled workshops. The Disability Hub has a lot of information about supported decision-making. Of course, our office, our website. We work with WINGS, the Working Interdisciplinary Network of Guardianship Stakeholders. We do occasional webinars on it. Various health systems, social service systems pull together, ask us to come in and train. So just a plethora of different opportunities. And thank you, Tori, for dropping our website. That's a good place to start too, into the chat.
Excellent. So I think we'll move on to the case because I think this will bring up lots of questions that Anita certainly will be able to help answer along the way. So like I said, the goal of a case study is to get as needed help. So I would like to introduce you to Dr. Claire McNeil. She's a MedPeds primary care doctor in the Alina system at the East Lake Street Clinic. She has clinic right now, so is not able to present her question live, but was able to record a short question and case scenario, and she's going to watch this like you can do after the fact and share with all of your colleagues to get some insight into how she can best care for her patient. So with no further ado, I will hand it over to Katie, I think, to start Dr. McNeil's question.
My name is Claire McNeil. I'm a MedPeds primary care physician at Alina East Lake Street Clinic. I'm here to share a case that brought to the forefront for me how important it is for medically complex teenagers to think ahead about transitions of care, not only for the medical issues, but also for legal aspects as they turn 18 years old, including guardianship. In July of 2019, I met a 15-year-old who, for this case, I will call Muhammad. Name has been changed. He was at the clinic to establish care with his mother. His history was notable for a history of perinatal hypoxia, seizures, and global neurodevelopmental deficits as a young child. He was diagnosed with a mild intellectual deficit and had neuropsychological testing at the age of 12. He had normal gross motor, hearing, vision, and growth. His social history was notable that he was born in Kenya and was one of 8 siblings. His father had died when he was 9 years old due to end-stage renal disease due to hypertension, and he had moved to the United States at 10 years old. His mom is a Somali-speaking woman, while Muhammad himself is bilingual. At the time of that initial visit at 15 years old, they had community support services in place, including a PCA for 3 hours a week. PCA would help with things such as restroom and shower use. He dressed on his own. He would eat on his own, but food preparation was helped by the PCA, and his mother stressed that he was always accompanied by someone. He also had a DD waiver at the time. Time subsequently flew by. 2020 began in the pandemic, and I looked back and I had a number of visits with him. At 16, I saw him in 2020 for 2 visits with acute needs focused around sleep habit concerns and gaming use and a well child check. He had visit at 17 years old where we discussed muscle strain in the low back and inactivity and mom's concern for getting labs to check and make sure his health was okay. He was still in school at the time. Fast forward to he's 18 years old. I see him in clinic and my heart kind of dropped. His mom asked, "Hey, we need documentation of a disability. We can't do anything for him with getting him a social security number without this." They were pursuing both guardianship and conservatorship. She shared at the time that he needed assistance with bathing, brushing his teeth, hygiene, deciding appropriate seasonal clothing to wear, though he could dress himself, anything around the home such as food, laundry, grocery, and obviously all financial decisions were done by his mother. He had a case manager through Hennepin County, and we talked through a few things at that visit, including the option for transition schooling, which he had already finished routine public high school, and mom was not aware of transition schooling for children, or rather for teenagers up until 21 years old. I asked about day programming, and mom just wasn't really aware of options and honestly wasn't very confident given the pandemic at the time for pursuing this. We talked about PACER as a potential resource with parental advocates for pursuing help. And I let her know that I would look into if the county could do any sort of evaluation to pursue things more quickly. I did let her know that I thought it might be necessary to pursue a repeat neuropsychology examination, which sometimes was booked out months. A letter was provided for the mother and the uncle who was present at the visit, detailing his medical history and prior neuropsych testing. I saw him last month in December of 2023, and now mom is official guardian for the next 6 years. They're working on pursuing U.S. citizenship, and inevitably he will need a citizenship exemption waiver form filled out. Now what to do? At that last visit, there was a concern from mother that the interpreters at our clinic didn't help enough, and luckily our Somali-speaking manager at the clinic helped rectify some confusion around what the role of interpreters is, and that they're not really case or nurse managers. So that's where things stand now. I still am wondering what I can do to help the mom, as knowing this is only temporary guardianship at this moment. And if I looked back, I think I would have thought about this a little more in advance or set aside a visit for thinking about this at a much earlier age before having that moment when he was 18. Thank you. Bye.
Thank you to Dr. McNeil for sharing her case. Yeah, so moving into the discussion of this, and obviously bringing in Anita's conversation around supported decision making. I know Dr. McNeil's not here right now to answer any clarifying questions, but I think as we get started, are there any clarifying questions or things that we think would maybe be helpful to Dr. McNeil to know about either the mother or the family? And or what are some supported decision-making recommendations that we can share with Dr. McNeil? So I will open it up to everybody right away. And you can either come off mute or put a comment in the chat and we can read to it there. So Heidi put in the chat, did the student take their diploma? Public transition schooling is now available in Minnesota up to the student's 22nd birthday. If the student has taken their diploma, they can no longer attend transition programming. So that might be some helpful information for Dr. McNeil to ask about. Great.
And I had the opportunity to connect with Dr. McNeil on this case just to be able to give a little bit more clarification. And one of the things that she was struck by was, I didn't know that like this was going to fall on me. I thought that there was something in place, either through the resources they were already getting through the county, that someone would have caught it there, or that this happened during like transition planning through the school district. So I'm not sure if we could kind of talk about what's in place to jumpstart the conversation, or where is this supposed to start?
Feel free to jump in if I see a few hands up, so feel free to jump in.
This is Heidi from Robbinsdale Public Schools, and it often does start in the school district, at least a discussion. And then often students are referred to county services and receive a PCA, and then it's more of a between the health community, their county services, and the school district in terms of families getting information from those three sources.
Great, thank you.
So I'm from Pacer Center, and we actually have a national transition program. And so we field calls like this all the time, where parents call us, their kids turning 18, what do they need to know? I didn't jump in when Anita said something about where does the conversation begin. We talk to parents all the time about the differences between guardianship and supported decision making, and what some of the new laws are, and what supported decision making is, because most people don't know about it. And we send articles to them about this kind of stuff. But we also kind of have a whole kind of approach to here's the things that happen when you turn 18, and these are the things that we need to think about. We talk about healthcare transition. We talk about transition into from school to vocational options, and we have a housing department, and we look at transition into the community and what their needs are for that. So if anybody has families or parents that they would like to connect us to, that's a huge part of what we do, and it covers several of our departments. And many of those areas we fall under one umbrella now. We're all kind of grouped together in a single silo so that we meet regularly, weekly, to discuss these things. The other thing is that I coordinate a program for the pediatric and med peds residents. And so what I just said, everything about what we just do, is kind of what I covered and just did an hour ago each month with the residents that are rotating on the adolescent rotation. And those students, Tori Barr being one of them a number of years ago, meet with a family that has a transition age child. And so these are all issues that both the residents learn about from us, so that when they go out into the communities, that they at least have an idea of what resources are available and know that they can refer families to us. Like, we don't expect them to keep up and know what all the different options are out there and how the laws are changing all the time, but also just to help them be more sensitive about all the different aspects of transition for their patients. So
Thank you, Linda. I appreciate that. Lisa Gemlow.
Hi, having just gone through this with my son, who is 18, my experience has been that information flows, but no one checks back, helps deter, so I can see how it can easily fall off the radar. And in the medical setting, you asked whether or not it's your responsibility. I actually, my experience has been that the medical folks are the most motivated, because you're going to experience glitches first. right? If you don't, are having trouble getting medical things done because there isn't, an ability to move forward once 18. So I found Gillette to be probably the most helpful and walking alongside with the medical social worker in that to ensure that. School, not so much. And in the end, again, it's often on the families, and people may not really get it. So I can see how that family, that things sort of fell through, not sort of understanding, because there's just so many complex systems. And then social workers change a lot. So depending on the size of your county, you may or may not. I've found myself, I have some great people, but I've also found myself educating case managers along the way as well. So those are just some experiences that I've had.
Thank you, Lisa. Any other thoughts or recommendations, things that come to mind that would be helpful for Dr. McNeil? As you're all thinking, I'm also going to enter into the chat right now those trauma-informed care principles that I think can be really helpful to reflect upon as well. Safety, trustworthiness, and transparency, peer support, collaboration, mutuality, empowerment, and then culture, historical, gender biases. So keeping those in mind too, how can we be making recommendations or aligning our practices in alignment with these trauma-informed values?
So I'm Kim from Park Nicollet Primary Care. I'm a care manager. I used to work directly in the clinics quite a bit as a care coordinator, and I think that primary care providers do tend in the pediatric realm to bring up guardianship. I think the miss is the understanding of really what you're helping families to get connected to. So they sort of, it's discussed starting at ages in the 14 to 15 range. But I think that idea of shared decision making is not really understood well in the primary care. And so, I mean, I did a lot of referring patients to ARC, to Alyssa, to our speaker, to just trying to help them get educated about guardianship. And of course, that change occurred. I've been a care coordinator for a long time, and the change from just send them to get full guardianship versus this shared decision-making process came into place somewhere within the middle of all that. And so I think there's a limited knowledge base for primary care providers, and I think they would breach it more if they had more of that knowledge base, because it is key to some of the patients that they work with on a regular basis. And so just a thought from the primary side.
Absolutely. And I think that was reflected in her video too, of which I would have started this conversation earlier. So yeah, I definitely think timing of that conversation, doing it right away. I think Anita just put into the comment, we'd love to see people starting to talk about transition at time of diagnosis.
Well, it's really about that knowledge base of that shared decision making, because I think primary care doctors also would probably start talking to families about helping their children to make decisions now, like when you're 14 and they're starting to, you know, add those conversations with your kids versus just kind of taking over because they don't have the capability in the eyes of the parent to make decisions, if that makes sense what I'm saying. But anyway, helping those primary care doctors to understand it would be helpful, I think.
Definitely. Thank you. Maureen, you have your hand up as well.
I was just going to add, I think we talked about this a bit the last session. So one thing I heard was like, I wish I had a designated visit or time to kind of address some of this. So definitely underscoring that. And I know all the challenges of implementing a model where you have those, but I want to reinforce that could potentially be really helpful. And then the other thing that I think was like striking to me was, you know, a lot of the information was sort of filtered by the parent in this situation. And we didn't really hear like what the patient wanted for themselves. And even if there was the opportunity to have that conversation or some method of communication with the patient as to like, hey, are there things that you want help with? Do you think you have the help that you need? Are there other people that you want to include in terms of like who helps you with things? So kind of like mapping it from a strengths perspective of like, who are your helpers? And we can have informal helper people and that don't need to be on pieces of paper. And then sometimes we need to have people on pieces of paper, right? So I think that would just be another thing like going forward, when you have patients with who may benefit from supporters, is like having that conversation or some kind of communication, even if it's like pictures on a page, like this person helps me, this person, like I can point to my helpers or something like that. So just wanted to add that.
And then Tony, you have your hand up as well.
Yes, excuse me, thank you. I'm actually a parent advocate. I have a young son who is 21 years old, and I'm thinking to universalize most everything. There's so much that has to happen at that 18 years of age. And I believe that the school system with the transition at right around 14, what if there isn't a way where we can have the parents know all that is coming within that one meeting? I realize that there's going to need to be more meetings, but if you can pull all of the different disciplines together to make sure that not only medical, but the county, the SSI, there's so much that they need to learn. And what I found is you find it and you learn it from all different places. But if we could have one place where that could all be communicated, and yes, at 14, maybe they'd say, okay, that's 4 years down the road, I'm going to just leave it go. But at least it would be the start. Maybe there could be a checklist. Maybe there could be something where you make sure that they refer to it. And of course, supported decision-making being of the utmost importance. So that's just my 2 cents.
Absolutely. That interdisciplinary connection is really important, that collaboration. Absolutely. All right, I will hand it back over to Tori to wrap up the session. But thank you all for engaging in this conversation. Hopefully Dr. McNeil will find some of this feedback helpful. So thank you, everyone.
May I just ask one or chime in just real quick, one thing?
Absolutely.
Because I say it to everybody who I can say it to, and I haven't said it to this group yet. But I'm a school nurse in Bloomington schools, and my big wish is that Epic or whatever electronic health system would just like we have, what is your preferred pharmacy? If you could just say what your school district is and who your contact there, the school nurse contact is there, because every child that is seen in medical has a school that they're ascribed to. And I think that would just be we can try to get releases of information for every provider, but if you guys were working on that and to be in communication with us too, I just think it would be wonderful. A wonderful next step. So thanks for listening.
Thank you.
Yes, thank you, Julie. And thank you everyone for your insights. The power of Echo and the power of these collaborative platforms is that no one person can know how to do transition by themselves, right? We all come at it from a different realm and training and background and experience. And it's only when we talk together about how we can really transform how we do this that we can make huge changes for our state, for our citizens, for moving across the country. So I want to thank everyone for coming, joining the conversation, and really look forward to many more conversations to come. Again, we thank Dr. McNeil for recording herself, which is no easy feat, and presenting her question. But I encourage you all, if you have a chance to come up with a question that you would like to ask the group, we would love to have you. Either if you'd like to go the recording route, if you'd like to present it live, that would be wonderful. Our next session is in a month, February 12th, transfer and integration into an adult outpatient practice. So we've been talking a lot about preparing and the pediatric side. So now we're going to kind of shift and see, what does it look like when a patient goes into the adult practice? How do we best integrate young adults into the adult world? And again, so here on the left is the evaluation. We really appreciate your feedback of how we can make this echo most powerful and helpful to you. And then on the right, if you have a case that's mulling around in your brain, we would love to talk about it. So you can fill out the short form and we'll reach out and kind of talk through. But again, Dr. McNeil, it was like 3 or 4 minutes that she was chatting, and then it led to this wonderful conversation. So thank you so much for coming, and we'll see you next month.